Hello, thank you for coming. Happy Friday, as always. Welcome to our community of practice. If you received our email reminder, you know that today the CBHJ, the Center for Behavioral Health and Justice's AOT team will be presenting on an upcoming statewide changes in Michigan. So this includes talking about PIHPs, CCBHCs, and touching on current legislation that will affect AOT processes. So as always, there will be a Q&A portion at the end, so feel free to raise your hand during the discussion, put it in the chat, or just save it to the end. I see many new faces in the crowd. We definitely widely marketed this particular COP just because CCBHCs, PIHPs is of interest to many people. And yeah, so we have a lot of new faces in the crowd, and I wanted to mention that the different opportunities that we offer widely in order to understand AOT better and provide support to those who work directly with AOT orders. So we have twice a month, we have Dr. Scott Smith is available for a drop-in AOT Q&A sessions. So anyone can come to these sessions with any AOT related question. This is a great resource to share with families and natural supports of AOT consumers, as well as other professionals in the field who work with AOTs. So as AOT gets more attention across the state, more questions are going to arise. So please share this information internally with community partners you may work with. To help you with that, we're going to go ahead and drop this Q&A flyer in the chat. So feel free to share that. The ones in July are going to be Monday, July 13th from 11 to 12 p.m. and then Wednesday, July 16th from 2 to 3 p.m. We usually do those on the second Monday and the third Wednesday, and every so often they'll end up on the same week. So that just happens to be this next time here. So yeah, the next thing I want to talk about is the AOT Toolkit. I know that most of you are aware of our toolkit and have visited it in the past, but we're constantly adding new resources that we've developed to help experts in our community partners. So I wanted to share this opportunity here today to show you all, or I wanted to take this opportunity to show you all some new things that we've added to the toolkit. So the first thing that we have is the AOT form guideline. This resource is a comprehensive guide that walks the reader through all relevant court forms used throughout the AOT process. So it explains what each court form is and when it should be used and when the form, should be completed and who it goes to. So this is kind of just like an overall cheat sheet of all the forms. So this resource is designed to provide clear, practical information about SMI, including what it is, how it presents, how it can be managed and supported. Whether you're an individual living with SMI, a family member, a mental health provider, a member of a legal team or healthcare system, the guide offers tools for understanding compassion and action. So this resource provides practical guidance for families and loved ones supporting someone with a serious mental illness, especially in situations where treatment may not always be voluntary. So even when engagement is court mandated or crisis driven, natural supports remain vital allies in the recovery. So we kind of generated this and created this with them in mind. Over surveying, peers and different people working with AOTs, we found that what families and loved ones really wanted was just more general mental health education. So that's why we've been kind of creating these different resources to aid with that. So as always, if anyone has any additional ideas on resources that we can develop that would be helpful for you and your work, or someone else that you may know, please, we're always wanting more ideas and feedback, so don't ever hesitate to share that with us. So yeah, without further ado, we'll go ahead and jump right into the presentation. Again, please feel free to hop in with comments or questions that you may have. If you're not familiar with who we are, we're the Center for Behavioral Health and Justice, or the CBHJ for short. We are a part of the AOT initiative. Our overall goal as a team is to support individual professionals and communities in navigating our AOT work, whether that be through education, collaboration, or research, whatever is needed, basically. Like many of you, our team has observed that things are changing in Michigan, especially in the mental health field. So we wanted to use this space to talk about some upcoming changes and start a dialogue on what that may look like. So what you'll hear about basically is, you've heard about who we are and what we're doing. We're going to do an overview on PIHPs, CCBHCs, legislative updates, and we'll go ahead and end that with questions at the end. So I'll go ahead and kick it over to Julia to go ahead and start. Thank you.
Thanks, Olivia. Okay, so this is just going to be a quick overview of what the PIHPs look like now and what changes are coming as of right now. So I'm sure everybody here is aware what a PIHP is. It's essentially the administrative body that basically manages funds for specialty behavioral health services. So they get money from Medicaid through the state based on the number of Medicaid recipients within their areas. So as of right now, there are 10 PIHPs. They have annual contracts with the state. So MDHHS has contracts with each one of these entities, these PIHPs, that look different from each other, not largely, but different from each other, to basically oversee and administer funding for specialty behavioral health services, mental health services. Right now, MDHHS is actually not renewing any of the contracts with these 10 PIHPs, and they're putting out a request for proposal summer 2025. I'm not sure if it's out or not yet. And they are basically proposing to go down to 3 PIHP regions. So I'm going to drop a link for the updated regions in the chat. They're basically looking for like a northern, they're looking for a central, and then a metro. So those 3 regions together. So Oakland, Wayne, and Macomb would be together. Sort of the middle of the state would be together, and then northern Maine, Michigan, and UP together. So the reason that they're doing this, they're saying they're looking for increased transparency. One of the biggest changes that's going to be happening is that no longer will a PIHP be able to be a provider. So they're requesting that it be completely separate. So if you are a PIHP, you have to operate exclusively as a payer entity. You can't contract any of your services out. You cannot be a provider. You need to have a complete separate, distinct board structure from the providers in that region. So that's probably the biggest change along with the regions that we're going to see. They must be, so anyone who's applying for this RFP must be a nonprofit organizing structure. So they have to be a nonprofit, although the state does say they're going to entertain some proposals from public entities like public universities or public-private partnerships. But you do need to have a nonprofit organizing structure. So you need a board, you need that type of thing. They also need to have a National Committee for Quality Assurance accreditation. So anyone who's applying to be a PIHP must have that NCQA, and they have to submit a regional proposal, so not by county. So they need to be prepared to act as a regional PIHP for one of the identified proposed new regions. So these are pretty big changes. They're expecting these new PIHPs to be up and running and starting service delivery in October of 2026. So this is sort of all we know now. We don't know who's going to be reviewing the RFPs. We don't know if it's actually going to be 3 regions, but these are just sort of upcoming changes for PIHPs that will have an impact moving forward. So I'm also going to drop the contract requirements into the chat in case you're interested in looking. And MDHHS has released a few press releases on this that you're welcome to check out as well. With that, I'll hand it off.
Hello, everyone. My name is Devon McCoy, and I'll be covering the first half of what is CCBHCs. So like PIHPs, I'm sure you all are familiar with CCBHCs, but we thought we would just kind of go over and give a brief overview. So CCBHCs, or Certified Community Behavioral Health Clinics, are federally recognized clinics providing 24/7, 365 crisis care, mental health, substance use disorder services, case management, peer support, and primary care screenings. CCBHCs are established under the 2014 PAMA Act and are required to serve all individuals regardless of insurance or ability to pay. Michigan's first CCBHC demonstration site launched on October 1 in 2021. So how many CCBHCs are there? Well, Michigan currently has 34 CCBHCs, 13 of which are full service demonstration sites, open to all. Demonstration sites are funded 75% by the federal government and 25% by the state. And the purpose of CCBHCs, they work to expand timely access to mental health and substance use disorder care. They integrate behavioral health with physical health services. They deliver high quality evidence-based care with measurable outcomes, and they fill gaps in care, especially in rural and underserved communities. In order for qualifying CCBHCs to receive certification, they must meet these following requirements. And as such, the CCBHCs must also directly provide these 9 core services unless otherwise contracting services out to other providers. And so, again, all of these services, they must either be provided by the CCBHC or be directly contracted out to the providers. And these services must be person and family centered, recovery oriented, and respectful of the recipient's needs, preferences, and values, with both person-served involvement and self-direction of services. And so I thought we can kind of go through each of these 6 requirements and kind of just give like some more information pertaining to like each of those. And so for staffing, qualifying CCBHCs must complete a community needs assessment for CCBHC certification and again for recertification. This assessment will guide the CCBHC in meeting certification criteria, which include staffing plans, quality and comprehensive service delivery, and the use of contracted providers. And then we'll talk about access to services. So CCBHCs must be able to provide a safe and functional environment, 24/7, 365 care, be locally accessible, support it with transportation if necessary, and offer telehealth. In addition to this, CCBHCs must oversee clinical service delivery and at the contracted service through contracted service providers. So if you are contracting out services, you must oversee those clinical services provided by those contracted providers. And you also must be able to ensure that those services are provided at the same standard at which the CCBHC is offering those services. And additionally, if the CCBHC contracts those services out to other providers, the CCBHC is still responsible for paying for those services. So the PIHP and CCBHC must work with Medicaid health plans and integrated care organizations to coordinate services for eligible persons served who wish to receive CCBHC services. The CCBHC has a partnership establishing care coordination expectations with federally qualified health centers to provide healthcare services to the extent that services are not provided directly through the CCBHC. And then amongst services offered, again, we have these 9 services here that CCBHCs must provide, and if not through direct service provisions through the CCBHC, they must contract those out to those contracted providers. And then quality and reporting. So reporting is annual and data is required to be reported for all CCBHCs person served or where data constraints exist. Although most data reporting requirements will be the responsibility of the PIHPs or MDHHS, some data may relate to services CCBHC recipients receive through those contracted providers. So collection of this data is the responsibility of the CCBHC. And again, for governance, so CCBHCs must show documentation showing that they identify as one of the following. Either CCBHC identifies as a nonprofit organization exempt from tax under Section 501c3 of the United States Internal Revenue Code, or is a part of a local government behavioral health authority, or is operated under the authority of an Indian health service, an Indian tribe, or tribal organization pursuant to a contract, grant, or a cooperative agreement or compact with the Indian Health Service pursuant to the Indian Self-Determination Act. And lastly, the CCBHC can either be an urban Indian organization pursuant to a grant contract or an Indian Health Service under the Title V of the Indian Health Care Improvement Act. Thank you.
All right, so I'm going to talk a little bit about how CCBHCs are funded. So right now, traditional CMHs are operating on that fee-for-service model. So reimbursement is being received for each service that they're providing. And we know that they're getting that rate based on the number of Medicaid clients that are in their catchment zone, in their area. CCBHCs in Michigan operate on a prospective payment system, a PPS. This is a model that allows them to receive their Medicaid dollars based on a predetermined sort of fixed amount for the services they're providing, rather than billing separately for each service provided. How they come up with that rate, somebody comes in, somebody does a sort of like Devon said, a needs assessment of their community. And so that daily rate that they're getting is based on the needs of their community, the needs of the client that they're serving, and they're getting that daily. They can also get money from SAMHSA expansion grants. There are SAMHSA grants that are given out to providers who want to establish a new CCBHC clinic, and also to existing CCBHCs for expanding and improving their clinics. So I just kind of want to back up and touch on, Julia talked about PIHPs, and I want to make sure we mention this first. I'm sure a lot of you know, but just to cover the base. The PIHPs are the ones kind of controlling the funding there that are going to send that money down to the CMHs and to the CCBHCs. So I want to make sure that we've covered that. So with the PPS system that they're using, these rates that they have are sort of rebased on a yearly basis to reflect their actual service costs. So if something changes, that's reflected in the rate, and they'll for the next year or whatever the sort of timeline is that they're rebasing, to make sure that they're getting the amount that they need to cover uninsured or underinsured individuals. So the goal of this type of payment system, of this PPS, is to make sure that the funding is more predictable and sustainable for the organizations that are providing such a wide variety of services. So like I said, they can get money there, they can get money from SAMHSA expansion grants, and they can also get money from other state level grants or appropriations. For fiscal year 2025 in Michigan, I think there was over $190 million of funding for expanding CCBHC sites and establishing more support for the state's demonstrations. So what does this mean going forward? There's a big shift that's happening here with the models in Michigan and how care is being delivered, how it's being funded, because these CCBHCs are getting that daily rate. Like I mentioned, it's more predictable and sustainable funding. It doesn't promote a volume of cases over quality of service, which we're seeing right now with the traditional CMH model. And ideally, it's helping to reduce strain and serve more of those individuals that are harder to engage. This is also ideally rising the bar for access to services, access to comprehensive services, because CCBHCs are required to offer that same day or next day access to care. They have that 24/7, 365 crisis service, and on top of that, list of other services that they've got to provide as well. So they also have a little bit of an increased accountability as a CCBHC. They've got to meet those eligibility requirements to get national certification. They have to be collecting that data. They're reporting on their outcomes, tracking their outcomes. So it's really hitting that mark where some places just aren't now. And then also boosting collaboration between those systems. It is an expectation that CCBHCs are building partnerships with other parts of the system of care, like hospitals, like law enforcement, jails, courts. It's part of the model. So if you don't already have those partnerships, hopefully creating them, really strengthening them, and improving collaboration across the system, which for us in AOT is already important. So this is even more so. So in terms of what CMHs should think about moving forward as this shift is happening, think about your current workforce and your infrastructure. Are you able to meet the timelines and the service requirements that fall under that CCBHC model? In terms of your data system, your capability, your reporting, how are you currently tracking outcomes? Are you reporting on those measures? How are you doing so? If not, how can you improve that? Because it is a good thing, whether or not you're a CCBHC, being able to do that and being able to track those outcomes is important. And then think about your existing partnerships, your coordination across these parts of the system of care. What do your connections look like? How can those be improved, especially for AOT, where these clients need that collaboration across the system? And like Devon talked about, you can also, like, CCBHCs can contract out services. They have to be able to cover 51% of them, the majority themselves, but the other ones can be contracted out. So that's another opportunity to establish relationships and partnerships with other providers, other people. And it's important to note too, the CCBHCs would be responsible for covering the payment of those services, even if they're contracted out. They still bill for those services. So I'm going to go ahead and pass this off to Kelly.
Hi, everyone. So we're going to shift focus a little bit to some legislative updates in Michigan, specifically regarding AOT. So this spring, there were 3 bills that passed through the Michigan Senate, and they're now pending a vote in the House of Representatives. So I'm just going to walk through each bill kind of one by one and talk about what they propose. So the first one is House Bill 4412. This one has the most kind of substantial updates to clinical and procedural changes for AOT. So first, this bill proposes that it will expand who can sign clinical certificates for AOT. So now, not just psychiatrists, but also psychiatric nurse practitioners and physician's assistants could sign those clinical certs as well. It also allows those professionals, so psychiatric NPs and PAs, to testify in court. Kind of the asterisk there is as long as they're consulted with a psychiatrist. So we're still kind of keeping in that layer of psychiatric oversight, but with just a little bit more flexibility. So more professionals are able to testify in court. This bill would also allow more people to petition for a second AOT order. So not just the treating provider, but potentially other people in the individual's life, like maybe a family member. Another big one in this specific bill is that second AOT orders can be extended up to 1 year. So the hospitalization portion is still limited to 90 days, but the outpatient piece can run longer. And there's also a new option for when someone isn't adhering to their AOT treatment plan. So rather than jumping right to hospitalization or changing the treatment plan, courts can now hold status conferences. So for those that aren't familiar with status conferences, we've touched on them a little bit in the past, but just for a review, there are an opportunity for an individual on AOT to meet with their judge as kind of a non-punitive check-in. They can be held when the individual is not adhering to their treatment, or they can be used as an opportunity to like celebrate somebody's success and ongoing engagement in AOT. So this bill just kind of adds in that language that status conferences can be held when there is non-adherence rather than jumping to hospitalization or changing the treatment plan. And then the last kind of point within this bill is that it formalizes the AOT treatment planning process. So it would require a psychiatrist supervision, and those treatment plans would need to be completed within 30 days of the order and filed with the court shortly after. So this just brings a little bit more structure and accountability to that part of the process. Okay, so the second bill in the House right now is 4413. This touches on mediation and service disputes. So this bill proposes that anyone who is permitted to petition for AOT can also request mediation if there's a dispute about services. So this could apply to family members, providers, or other involved parties, advocates. So for example, let's say like a family member has been really involved in the individual's care and is worried that the AOT treatment plan isn't being followed. Under this bill, they could formally request mediation with the CMH or service provider to resolve the issue. And again, that is anybody who is allowed to petition for AOT can also request this mediation services. This bill also proposes that CMHs and contracted providers are required to notify the individual annually about their right to mediation as well as at the start of services. And then the next bill, House Bill 4414, this touches on AOT diversion for misdemeanors. So basically, if someone is charged with a misdemeanor and mental illness contributed to the offense, they can be assessed. And if everybody agrees, they can be diverted into AOT instead of being prosecuted. So the everyone agrees piece is key. That includes the judge, defense attorney, and prosecutor all have to sign off. It also makes clear that participation in AOT is separate from bond or release conditions. So if someone is in their AOT, their legal status doesn't depend on their treatment compliance. Those are two distinct things. And finally, once the AOT treatment ends, providers have to notify the court and prosecutor so there's clear communication about when services are complete. So just to kind of recap what we just heard, some key takeaways and summaries. With these proposed bills, if they were to pass, that means that clinical roles may expand to include psychiatric nurse practitioners and physician's assistants. They may be able to be doing more in the AOT process, such as evaluation, clinical certs, and testimony. We also could be looking at longer AOT orders and more tools like status conferences to support engagement without going straight to hospitalization like we talked about before. More people will be able to get involved in the process, whether that's through petitioning, mediation, or diversion. And finally, the bills introduce more formalized processes, including the court filing timelines, documentation requirements, and consistent rights notifications for those mediation services. So in terms of where things go from here, the bills are currently sitting with the House Health Policy Committee. So they'll need to be reviewed still and voted on in the committee before they can go to the full House floor for a vote. And then if any changes are made, they'll go back to the Senate for reconciliation. And then assuming all changes are accepted, they would head to the governor's office for a signature. This process is assuming that everything gets passed. So that's kind of where we're at with the legislative updates. We will continue to monitor these and make sure updates are given as things progress. But that's all I have for the legislative updates.
Wonderful. Thank you so much, everyone, for presenting. Yeah, we can go ahead and transition into our Q&A at this point. Yeah, so we had some conversation in the chat where someone asked, would status conferences be required or optional? And the answer to that is that they would still be optional as a response to a notification of noncompliance. And, and Mac brings up a good point in being like, if judges aren't doing them now, then why would that necessarily change? And I think the conversation around that is that it is, introducing it into law is making it a more formalized option for judges, in that they might be more inclined to entertain that as an option if it were formally in the law, and maybe just, I don't know. The term coming to my head is spreading awareness of it. That's probably the wrong term for it, but yeah, just making it known as an option. Another question, will there be any accountability and address in the inhumane conditions within these mental health institutions?
I can take that question, Ashley. There aren't any AOT specific bills that are addressing the question that you have. However, I am aware of a bill that is forming a recipient rights subcommittee. I have not read in detail what that bill all entails. However, I am just kind of under the assumption that a recipient rights subcommittee would address any recipient rights issues that are happening at the institutional level and CMH level. So
Thank you, Jenny, for answering that. We also have Lisa in the chat asking for House Bill 4414, who determines that the mental illness played a part in the offense. This seems like it should involve a psychiatrist to determine if someone, if something was due to a mental illness or a result of substance use. It's a good question.
I can take that. So it's not necessarily, no one has to prove that mental illness led to the misdemeanor. It's more just saying there's an opportunity if someone clearly has serious mental illness, or they think someone clearly has mental illness, they're basically saying it's okay to request this, that they get an assessment for AOT. So then they go to a psychiatrist or a licensed psychologist or a physician to do an assessment, determine if they meet criteria for AOT. If they do meet criteria for AOT, they move ahead with the hearing. So they do have to go through that whole AOT process. They will need to get clinical certificates and all that sort of stuff. And if a prosecutor, defense attorney, judge, or the individual object to that at any time, then it does not go through. So it's basically everyone needs to be supportive of it, thinking, you know, everyone's kind of on the same page. And there are those checks and balances. They will have to get assessments. They will have to go through that process. It's not like a wave and stip thing. So I hope that answers your question.
We also have Allison in the chat asking, where is West Michigan in the proposed 3-section PIHPs?
So essentially the proposed 3 PIHPs, West Michigan would be in that southern portion of the state. So that would be that southern lower half of the mitten, if you will. And so we would be included all the way over to Detroit as the answer.
Wonderful. And then another question is, how do we request a status conference, and is there a formal document to do so? Jenny had answered that if the law passes, most likely the scale form would be updated to do so. If that doesn't happen, we do have a one-pager that I can go ahead and drop in the chat of strategies in introducing that conversation to your judges in your county. It is really a collaborative process with you and probate court staff in working together to establish what works for your judge. If they're open to doing it, it's there's not a formalized process at this point pre House bill, but we can definitely offer some more information in and how to introduce that conversation in your county.
Another great question, Dr. Spurlock, about the expanded use of AOT for misdemeanors. What if they don't have Medicaid? Will there be funding? So that's a great question. And I think it's something to look up. I would imagine there's no funding allocated for it right now, but I think it's something worth mentioning. So I know a few people on this team have mentioned, perhaps there should be contracts with, psychiatrists to be able to do that, those assessments. And we certainly have brought up the administrative and burden and others that comes with AOT, particularly for individuals who do not have Medicaid. So I wish I had a better answer for you, but just know that is top of mind. Those issues are being brought up, but you're welcome to bring those up as well.
Wonderful. Okay, so Ashley asks so many questions about providers and orgs that get funding from PIHPs. Would this now come from the state?
Everything's still going to go through PIHPs. They have fiduciary duty to CCBHCs and CMHs. That's not going to change. It's the composition of the PIHPs and the separation of PIHP from provider. So the money goes from Medicaid through the state to the PIHPs, then to the CCBHCs and CMHSPs.
Wonderful. Thank you, Julia.
Have a question for others if nobody's got a question. I would love to hear from somebody if you're at a CMH that is now a CCBHC or just at a CCBHC in general. I would love to hear about your experience. If you're at a place that became a CCBHC, I'd love to hear if there were any shifts that you had to adjust. Was there sort of like a culture shift? How did you have increased collaboration? How was it? How did it go? I'd love to hear.
In my previous life, I was at a CMH that became a CCBHC, and it was a lot of growing pains. There are a lot of, data collection points that need to happen, and that kind of increase the administrative burden on the staff that were providing direct care services. And it was kind of building the plan as we go. Like, we need to collect these data points, and it's really important that we do so. So, let's do it this way, and then try to figure out the best way to do it after the fact. So, in my experience, there was just a lot of growing pains in making that shift. And since I left that CMH, I have also seen a lot of expansion and really cool things that they're offering to the county to be able to, provide more care for the county's needs. So I think, just in my opinion, it was worth it in the end, but it is a huge undertaking and process to go through with a lot of growing pains to get there. However, I did leave kind of during that process, so I don't have the full picture, and I would love to hear from somebody else that may have a fuller picture.
I concur with what you're saying, Jenny. I think it was huge growing pains, but I think there's still growing pains because what it did is open the door wide open for anybody to come in for services having to be served with less staffing because there's been that ongoing staffing crisis. And so we have thinned the herd with our staff and lost some very seasoned staff as a result of it because of the overworking and the overloading of everything. I think it's also for my community mental health. We have become a dumping ground for other community mental healths and other counties because they don't have CCBHCs and they don't take people who don't have Medicaid. So we have people from every county around us coming to us because they can't get services someplace else. So that just increased our workload compared to just getting the people within our county. Now we have all those extra people that we can't say no to outside of our county. So I think it's a double-edged sword. I think it's wonderful for the people who weren't able to get services before, but for the people who have to serve them, it's been a real difficult transition.
I really appreciate that insight, Stephanie. Thank you. And Jenny.
We encounter such problems too, because I'm a manager of an ACT program, which is Assisted Community Treatment, and this is for the the CCBHC program, especially the man shortage, the personnel shortage, and the demand of community mental health services in the Metro Detroit area. It is becoming monumental. There's also the budget constraint too. There's a cut in from the DVN and other places. So it is becoming more and more burdensome, and especially those AOT patients who are more serious patients who violate that, who does not care about that, who does not even want to take part of that, even though they have the AOT mandate on that. It is very difficult for us to make them follow. And if you can just keep going back and forth in court, I don't know what court can do. They can only send in jail, and then that will make it worse. So the changes are, these are the good news in future, but it's yet to see that. It's yet to see that.
Thank you so much for that insight. I appreciate that. So I wanted to address Carol. Carol, you asked, can you give an example of a successful rural CCBHC? I was wondering if you could rephrase the question or define successful in what you mean by
you know where I'm coming from on this. I mean, we just can't do this. It's not even possible in our rural areas. And so you said there were 13 pilot programs, and I thought I heard you say that some were rural, and I'm wondering what their challenges and successes have been.
So I know, Julie, you mentioned Pines. Pines is a CCBHC?
Yes, Pines is a CCBHC, and I know they do a lot of great stuff, but they're really innovative, and they really have embraced like mobile crisis and what they can do with mobile crisis as a rural county. And I think they were able to bolster that through their CCBHC status. So I can't speak to, like what successful means as far as like measuring a CCBHC, but I can say that Pines Behavioral Health is a CCBHC, and they're rural, and they are doing some really cool stuff. So
I will say that so I'm with Lifeways, which covers Jackson and Hillsdale. And we're a CCBHC, and I just know that there's challenges. I mean, obviously Jackson and Hillsdale are very close together. So the resources that we have in Jackson, they're very different from what we have in Hillsdale because Hillsdale is a rural community. So there are challenges in like getting people like connected to community resources, and also getting people engaged with any like treatment in Hillsdale just because of like the lack of resources. So there's not transportation when someone lives, miles away from this, the service site. And, I think we try to share staff between, Jackson and Hillsdale. So that's just something that works for us, but I'm just speaking to some of the challenges that, just affirming that it's true that there are challenges trying to implement that in a rural area. So
Thank you, Clarissa. So Haley asked a nice clarifying question with the PIHP changes. If PIHPs aren't able to provide direct services, would it be the CMHs themselves or their contracted agencies providing the services? How will that affect the few CMHs who are also currently PIHPs?
Answered this to the best of my ability, but I know Scott Smith is on here and he might have more information. But basically, currently the CMHs that are their own PIHPs are going to be sort of their own metro region. So it would be one PIHP over those 3 regions. So if you're delivering services at all, you wouldn't be able to apply to be a PIHP. So my guess would be and you couldn't contract with providers either. So it has to be fully separate. So it's going to be a different administrative body altogether.
Yeah, and it's in many ways won't be entirely different from the way it's running now, except that you're probably going to have a separate, distinct corporate entity, and most likely a separate board, just to erase the, possibility of being perceived as working both sides of, the process.
Wonderful.
My question is that why did the need arises that we have a state body, we have a county body, we have the local contractor, and we had a state to oversight. Why this change is needed now?
Bear in mind, this is probably more opinion than anything else, but I think the challenge is that whatever the promises of the PHP system were, they've yet to deliver on that. We know that especially prior to COVID, most PHPs were in the red most years. So many limitations, and one of, I think, the real challenges is that it really doesn't incentivize things like AOT that can reduce hospitalizations, because it does not allow for a sharing of savings. And so without a value-based funding component to it, where let's say you reduce hospitalizations by 20% for your CMH, without a way to actually recoup the cost that you spent on additional ACT teams, maybe spec res, et cetera, these very expensive, albeit highly effective interventions, then there's really, it just continues to put you and the CMHs in a place where you can't reasonably get ahead, and you're having to make choices based on this financial system that really doesn't make a ton of sense. And I know that the CMHA has spoken fairly, broadly about all the many limits. What I'm really concerned about with the current attempt to reorganize is that I think we're trying to solve the right problem, but do it by just tweaking the already ineffective approach to it. And so I think what we're going to, really be up against is how the uncertainty on a national level around Medicaid funding and the future of things like that really are going to then get passed down on the state level. And as we all know, with the original PHP model, the dream, the impossible dream, was that general funds would eventually be phased out because it wouldn't be necessary, because this was a sheer act of genius that was going to perfectly solve our mental health problems. And obviously it hasn't delivered on that. And this, I think, is going to be an ongoing challenge and requiring a lot more general fund dollars than anybody proposing that PHP change really wants to acknowledge. And I think too, and I had this conversation the other day with a provider that, you know, in some ways, Michigan really hasn't taken advantage of opportunities to modernize its mental health system. And instead of investing in, you know, our mental health system, both in terms of infrastructure, in terms of human resources, I think we're continuing to do the failed approach of excessive cost management. And we know that the key to cost management really could boil down to two straightforward changes. One, reducing the high utilizer consumption of resources. We've known since almost 19 always that a very small percentage of consumers are responsible for the majority of expenditures. So that's where AOT comes in. That's where our other services that are offered under AOT come in. The other piece of that is really investing in, you know, human capital. And I think something that we have to maybe as a profession have a come to Jesus about is that it is not inherent to our field that there be high turnover. High turnover occurs for specific reasons. And I think it's a greatly underestimated cost of delivering mental health services. And I would love to see an initiative where we start looking at ways to address those challenges that lead to high turnover. And the good news is, you know, we've been studying that at least on the corporate level since the early 80s, figured it out pretty well. And I think we could really benefit from kind of imposing some of these changes to create environments where we don't have, as Stephanie mentioned earlier, a system that works people to death. And, you know, I can say personally, as both a clinician and as a professor of social work, that I hate hearing from students who not only left an agency because they were burned out and overworked, but they left the field entirely. And I swear if I get one more business card from a former student telling me they're selling real estate, I'm going to lose it. Like I've invested way too much in them to see them just give it up. So I think these two things really, really could make a much bigger impact on overall effectiveness and cost.
Thank you so much. I appreciate the robust discussion that's come out of this and appreciating the things that we've acknowledged and knowing that there is no clear pathway forward in a lot of these. But yeah, to have the opportunity to come and discuss and collaborate is truly valuable. So I went ahead and found our one pager on status conferences. It does say basically what status conferences are, you know, strategies and how to introduce that conversation with your judge and the benefits of status conferences. If you're not familiar, definitely, or even if you are familiar and you'd like, you know, some tips on how to, you know, how to introduce that into your county, go ahead and check that out. I personally love status conferences. I love hearing that counties are trying them out. You know, it's really about that, you know, your judge being open to allotting a little bit of time or however much time that they feel is necessary. You know, it can be a response to non-compliance. It can be, you know, the next step before having to, you know, to hospitalize again. Yeah, there seems to be a lot of success with status conferences in the judges that are uh, in that are holding them. So yeah, definitely check that out and let us know if you have any questions about that or want to know about more folks in the state that are doing status conferences and their experiences with it. If you're new here, we've done things like how to conduct an AOT assessment and county profiles and how to build relationships with your probate court and all that valuable stuff. Thank you so much and have a great rest of your day.